Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Today, how can peace building be a framework for public health conversations? John Paul Lederach, professor emeritus at the University of Notre Dame and a senior fellow with Humanity United, and Dr. David Addiss, special advisor to the Focus Area for Compassion and Ethics, or FACE, at the Task Force for Global Health in Decatur, Georgia, talk with me about their work in global health and peace building in some of the world's most violent and intractable conflicts, and how some of these concepts could be used in an increasingly polarized America. Let's listen. John Paul Lederach and David Addiss, thank you so much for joining us on Public Health on Call. Let's start with you, David. Could you introduce yourself and tell us a bit about your work?
Yes, my name is David Addiss. I am the director of the Focus Area for Compassion and Ethics, or the acronym FACE, at the Task Force for Global Health in Atlanta. By background, I'm a medical epidemiologist. I worked in migrant health as a physician for several years and then became a medical epidemiologist at Centers for Disease Control.
And John Paul?
Yeah, I'm John Paul Lederach, and I'm a professor emeritus from the University of Notre Dame at the Kroc Institute for International Peace Studies and a senior fellow at Humanity United. I've focused most of my life work on responding better to especially protracted and armed conflicts in many parts of the world, and have been a part of the wider conflict transformation and peace building fields as they've been growing over these last years.
And you both came to us with, an idea for an episode because you've been working together and thinking and writing particularly about peace building and conflict in this moment where we are in the United States. And so, John Paul, could you just set the scene for us a little bit?
Sure. Well, a lot of the concern we have in places that we've worked internationally have been conflicts that have not only been what we might refer to as highly toxic in their polarization, social and ideological and political, but have transferred into active cycles of repeated violence that have lasted a long period of time. And out of those experiences, we have a concern for both prevention and ecosystems that are contributing to collective well-being. But we're also dealing often with very intense, acute situations of conflict where forms of dialogue and negotiation are needed in order to try to reduce violence while you increase better relationships and make better decisions for the collective population affected. And what we've been seeing in the United States in particular over the last years is how much this toxic polarization has been increasing, particularly across identity lines. Some of those have elements that feel a bit geographic, rural, urban divides. It could be by regions of the country. And certainly as politics, our electoral periods are becoming ever more divisive. We have great difficulty. We're paralyzed in a lot of ways around our capacities to make decisions. And we're at the precipice quite often of forms of not just misunderstanding and deep difference, but at the edge of violence. And so a lot of the work that I've been trying to do with great colleagues across the country is how to think better about stitching conversations and relationships in the challenges of highly toxic polarization.
And David, do you want to center us in your work here?
Yes, I would say that all the factors that John Paul has outlined deeply affect public health as well. Polarization has a measurable effect, both the messaging, the uptake of interventions, but also this being on the edge of violence, and in some cases, acute violence. There's a public health cost to that polarization. And so from a just pure public health perspective, polarization has become an issue that we need to grapple with.
We're going to start off with you, John Paul, for this. Can you define peace building for us and maybe give us some examples of what that looks like?
Well, the concept is a more umbrella-like concept. It includes a lot of subcategories of engagement. Probably the most well-known are people who work in forms of conflict resolution, often forms of dialogue and bridge building across divides. But we also work extensively around issues of restorative justice, dealing with systemic and structural issues that impact why it is that people feel that they are drawn toward or feel they need to use violence to achieve their means. We work, as I would put it, at trying to bring together unlikely alliances in order to create a confluence of ability to shift social change and change in relationships that make a significant difference, that reduce violence but increase more robust and better relationships and justice in much of what we do.
If Lindsay, if I could add to that, one of the things that John Paul has really excelled at and brought to our attention is the need for, in a sense, peace building at the micro level. So he mentioned people signing treaties and conflict resolution, but really peace develops at the level of the community or the sub-community. And that's that relational dimension that is often missing, both in public health and in the more formal forms of peacemaking.
Could you give us an example of what that's looked like in other contexts?
Sure. So I've worked in a lot of places from Latin America to Asia, Africa. A lot of those are places that countries have had internal armed conflicts over decades, quite often. So the most recent and probably most extensive piece of work in Latin America that I've had is in the country of Colombia. So on one hand, we were involved in giving support to and certainly encouraging what became a negotiation between the Colombian government and the armed insurgencies that led into a formal signing of a peace agreement. But on the other hand, I'd say 90% of my work in Colombia has been at local community levels, people that are most impacted by that violence and the ways that they interact and the divisions that exist within their communities and how communities mobilize around not only addressing their differences, but advocating for the well-being of where they live and the things that they're most impacted by. I tend to gravitate toward the ideas of conflict transformation, which is having people think about what is the change that they hope to engage in rather than exclusively a solution that quickly takes care of things. So, concrete examples in one of the regions of Colombia, we have what we call improbable dialogues. And probable dialogue is that you're bringing together people from that particular region, sort of at the level of a small state here in the US, who are representing very different sectors of that society, from business to politicians to indigenous people to agriculture and landowners, coffee, a whole range of people that would not normally be together. But once they begin to meet, they host and own a place where they can exchange their views of not only what has transpired, what they need, but also the visions they have for where they live. And those improbable dialogues have been going on for some time, and they've been exemplar in some of the ways that we need to do more of. So not thinking, oh, I'm waiting for the national policy to get perfect before anything's going to happen, or I'm waiting until the police do it or the mayor does it. This is truly about the idea that this is accessible, the principle of accessibility. What do I have access to now? And who do I have access to that I can work in directions not only to rebuild trust, maybe more significantly in the early stages, rebuilding trustworthiness and how we can actually talk together.
What would an improbable public health conversation look like in the U.S. right now?
One of the things that's so fascinating about health and peace building have always had a longstanding connection. Some of my earliest work in Central America was with people who were running mobile clinics in Guatemala and other places. So they were nurses and healthcare supporters. And what was fascinating about it was that every place that you went, people needed access to that health. And so if you worked with people who were actually moving around providing health, they were crisscrossing boundaries. They were moving across places that were controlled by a militia or by government. And yet all of the people needed access to something that was about their well-being of their family and their community. And I think that's part of where we need to start. I actually get quite a few calls from local hospitals and clinics who are saying, we're feeling pretty paralyzed right now. We don't know how to talk about things, even within our own staff, because we don't know what's safe to do. So take the principle of accessibility, imagine a local community, county level or city level, or even a local hospital. How do you set up the possibility that people could have an opportunity across differences of where they touch the system of health and differences of opinion to create smaller groups of better conversation that permit people to surface what it is that they're really concerned about, but also to engage with viewpoints that are different than their own. The emphasis would be twofold. First, that they participate in helping to define that process. So define your process before you jump to the content. And second, to stay with it for a while so that you can truly understand the lived experience that people have, where they're coming from, and how it is that they make sense of things. Because conflict is rarely about just minds meeting and data. In fact, facts and data are often contested. What matters most is the relational context, the quality of relationship that permits people to sit together and understand how you could interpret this differently and why it is you have fear or perceptions that are deeply different around a particular issue, and how it is that you are creating reliability of what you understand. Now, in the science world, we have certain approaches to that, which often take the form of evidence and conclusion. If you can separate content from relationship, you have to do both of those things in conflict work. You have to be able to talk about what it is that are the issues, but you also have to be able to see what are the perceptions, the understandings, and the sense making together we need to do. Which is why I said I think the key to this is not so much assuming that we're going to immediately create trust between us, but that we can together create an agreed form by which trustworthiness of what we're doing increases. And where that happens, I think that interaction has potential to improve things where people actually live. That doesn't mitigate or minimize the need for a more national level or other levels of the system to engage. But I do think it requires us to take uncomfortable journeys of engaged dialogue and to be able to sit more with greater patience and a longer time with deep difference. And I feel on both sides what's happened with the polarization is that people are driven to their enclaves of where they feel most comfortable. We actually are very suspicious that anything else is possible. And I'm here to say I think it is, because I've done it in war zones. Don't be paralyzed. Don't wait till somebody gets the perfect solution, because there isn't one. Be a part of fostering the trustworthiness that you're willing to enter into and to do it with people that are improbable.
Yeah, just to pick up on, for example, the vaccines conversation in the US, it very often gets framed as an evidence conversation. Like, show me the evidence, show me the data about safety and efficacy. But you're saying it's actually a relationship conversation, if I'm hearing this correctly.
Yes. Well, and I would argue that science believes that too. Why do you have peer reviews? You're placing something in the context that people have to have a relationship to test and exchange and view and ask deep questions about whether this holds or not. And I think what happens is that because we've arrived at a place where there is evidence, we assume that evidence on its own will be convincing. But in polarization, evidence is not convincing because people do not trust where it's coming from. And that requires us to understand that we have to also move to the relational context in order to engage differently than we might have assumed was possible at other periods of time.
See, if I could just add a couple of things. The irony here is that the scientists treat the evidence as temporary. It's conditional on new evidence. And so a lot of the challenge comes from how the evidence is communicated. It tends to be communicated in an absolute term, whereas the scientists generating the evidence are well aware of that. That's the best interpretation of what we know now, but that could change. The other thing I'd like to suggest as a relatively recent example, was in the HIV/AIDS epidemic when ACT UP stormed the offices of CDC because they were not getting any support or responsiveness to the pandemic. Some very enlightened public health officials, Jim Curran and others, basically opened the door and listened. And they became not only allies, but friends, coming from very different perspectives. And there was a relationship there that developed, a trustworthiness that developed because of that openness to really hear the opposing view or the pressure that was being put on CDC to act when the structures, the norms at CDC were not necessarily geared toward rapid response. So that's a great example of relatively recent history where that relationship development really propelled the advance of public health.
I was going to make a bridge from that example that David gave to the work in peace building in a setting where there's more open violence. If you're moving across groups that are deeply separated, we often are unable to use a model of mediation that is about an outside neutral coming in from that context. But what is more prevalent is that people who are proximate form a small group, and what they refer to that as is credible messengers. Yeah, people who have credibility and trust with one sector. So if a small group is trusted by each of the groups, you create this idea of how it is that you begin to rebuild trustworthiness in the actual conversation. And I think part of what may be useful in the public health sector is this idea of what would credible messengers look like that are moving across the deep differences that we have. I'm not sure that anybody's asking it in that form.
Yeah. And so, one thing I want to raise here is that I think what people are seeing now with different appointments that have been made, with different structures that are being dismantled at the federal level, is they feel like now there's an opportunity for them to be heard by these structures when that may not necessarily be the case.
Well, I also want to make a distinction between the drive to be heard and the drive to control. And I think one of the things that toxic polarization does is it drives to control narrative in a very reduced space. And so we have to open up better ways to engage in how we listen with each other. But we have to release the notion that we are going to singularly control narrative and understanding. And I think that's actually playing out on both sides. Even it's almost hexagonal. It's like there are multiple ways that this is happening. It's not a singular binary. But that pushes in the direction of some things that we tend not to be as comfortable with, which is how do I openly define what I see as being clear and evidence and truth? At the same time, remain open. That is, remain non-anxious about other expressions that people may have because of their view and experience. And the third element, stay in relationship. Because what polarization does is it drives you to extreme forms of presenting what you believe. It drives you to listen with your eyes, who's saying it, and depending on who I see says it, I already reject it. So I don't actually engage in any form of deeper listening. And the third is we destroy our relational fabric. We just don't have contact and exchange and a stick-to-itiveness that is required to work through deep difference.
What does this actually look like in practice, and who is responsible for bringing these people together? Where are these conversations taking place? I think there's an argument some people would say that, they're taking place on social media, or they're, in your experience, and either of you can weigh in on this, how does this work start?
I think that's the key question, Lindsay. Who's responsible for having these dialogues? Who's responsible for initiating or staying in relationship with people with whom we disagree intensely? I think the answer is all of us are. And sometimes our leaders are able to do that. Sometimes they're not. They're paralyzed by some of the same factors, and even maybe more so by the structures in which they're engaged and employed. So I think there's an element at which this is a responsibility for all of us. And we do see some points of light around this, particularly on the vaccine front. There's an organization called Voices for Vaccines, which is made up of parents and people in the public sharing information about vaccines, trying to dispel misinformation, but very intentionally inviting people into relationship with that issue and with each other. So there's some virtual examples of this, but there's also, during the COVID pandemic, people working with barbers, local barbers, who would be able to share information about the COVID vaccine, the virus, and the potential advantages of being immunized. And they were trusted messengers. And they paired with public health people to actually meet with the barbershop customers. So it's exactly the same sort of model that John Paul is talking about. We don't see that as a major part of our public health armamentarium, though. By definition, in public health, we deal with numbers, we deal with populations, and that one-on-one, face-to-face relationship development is often secondary to our work to improve the health of populations.
John Paul, I'd like to give you the last word here.
Sure. Let me just say that two of the most significant dynamics that repeat in really toxic polarization. The first is that people blame as a way not to take responsibility. And the second is that quite often it's highly reactive. So I react to what's happening rather than being propositional, rather than proposing something. And I think the shifts that have to happen, and I'll go back to my early case. A number of the examples that I think David was giving was about actual places where people had face-to-face relationships. So start where you're at, the proximity of your community. How would you imagine that you could move from blame to responsibility and from reactivity into proposing, and propose it with somebody who is slightly different than yourself? So enough of a reach, and I think we know who those people are, and closer it gets to home. And so it's hard work, but I also think that it comes to where people in everyday life have their questions. Do I vaccinate my kids? What is going to happen in the school? Will I have access to the clinic or the hospital? Is it safe to go there? These are all things that are like tiny little openings. These are all things that we can make a difference on. And I think that's what we really need to become very creative about. How to recognize where opportunity exists where we live.
John Paul Lederach and David Addiss, thank you so much for being on Public Health on Call.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.